My name is Adnan Siddiqui. I'm a professor of neurosurgery at State University of New York, University at Buffalo. This is an interesting case where primary coiling was employed for treatment of a paraclinoid aneurysm. The vast majority of these aneurysms are typically treated with flow diversion. However, that does come with the additional need for dual antiplatelet therapy and a different types of risk in terms of risk to the entire distal circulation as well as occlusion of the vessel. Primary coiling, progressively underutilized in this location, remains an excellent modality for treatment of these aneurysms. As long as the aneurysm neck is narrow, primary coiling can work very well and does not require dual antiplatelet therapy or risk the entire carotid artery. However, there remain risks of thrombus formation and stroke and hemorrhage anytime you're treating an aneurysm using the endovascular technologies. The strategy here was 6 French system using benchmark guide catheter and an 0165 microcatheter system over an 014 wire using hydrogels for coil occlusion. Here you can see groin access established using a 6 French guide. Once that is in place, then VTK catheter over an 0135 wire is brought up into the distal cervical carotid. The benchmark guide catheter is advanced into the distal cervical carotid and cerebral angiography is performed. You can immediately see the relatively narrow neck, laterally pointing paraclinoidal aneurysm. High magnification is now being used to visualize the aneurysm in optimal dimensions. And then again, you can see very clearly a relatively narrow neck is noted in this aneurysm. The microcatheter is brought all the way up to the paraclinoid, and as is expected many times, the microcatheter simply follows the flow into the aneurysm. And the microcatheter has now been brought into the dome of the aneurysm, and now coils are being placed. But when you start putting coils, you start appreciating that the base of the aneurysm has a wider neck than one would have visualized based on the angiogram itself. So very careful repositioning of coils is done repeatedly to make sure we have a good coil mass which is stable and not going to herniate. However, each subsequent coil becomes much more reliable because it ensnares in the originally placed coils. The coils are progressively pushed in. Now, native road mapping is continued just to make sure that we do not violate the boundaries of the parent vessel. Once the microcatheter has delivered the last coil, it's withdrawn over the last coil and an angiogram is performed to see occlusion rates. Here we do a final angiogram showing no distal vessel branch occlusion. This is the second case using coiling in the same technique, only we're catheterizing now the left carotid artery with the VTEC catheter. An angiogram is performed using this approach to look at the cervical anatomy, and then that is used under road mapping to selectively catheterize the brain. Here you see the 035 wire into the petrous carotid, and once there, the VTK catheter is left in the arch, and the benchmark 6 French guide is advanced distally into the cervical carotid. Cerebral angiography at a baseline reveals what appears to be another medially pointing paraclinoid aneurysm, and that is very typical of a superapophyseal artery. Again, given the flow rate, it appears to be significantly slowed flow. Catheterizing these aneurysms appears difficult. However, flow, which results in the aneurysm in the first place, will typically guide the microcatheters in the right direction with minimal manipulation. The microcatheter is now advanced. You can see there's some trouble advancing the catheter given the fact that the narrow neck can sometimes impede. Even in the narrowest of necks, you can see the first squall keeps desiring to leave the confines of the neck of the aneurysm, and the microcatheter needs to be pushed and pulled to find the right angle to deliver the coils in the right place. Once the initial basket is made to satisfaction, additional coils can be placed in this same configuration with much greater effect. An angiogram is performed after the first coil to make sure no vessels are being violated, and now additional coils can be placed much more comfortably inside the confines of the first complex coil.